Hi, my name is Louise. I'm one of the physiologists here. We're going to give you a quick demonstration on how to set up the Trilogy Evo. This is not one of the machines that's been on recall by Respironics, so we're safe to go ahead, but we will be using a circuit that has filters in anyway, just in case. So first thing we need to do is to plug in the wall oxygen. There is a little notch on top of it that just lines up with the hole in the wall. Like so. And then we can just turn it on, and then it's quite happy. So the machine may well be set up already in CPAP passive mode, which is what we wanted to say. If for some reason it's not, under the wheel, the setting, if you go into mode CPAP, it gives you the different options here. So we just need to make sure it is the CPAP that is selected. Then the other thing that we can set, we start off normally on the protocol with an FiO2 of 60%, and then that is titrated down as per your patient's needs. So your patient, here's one we prepared earlier. So because we're using a closed circuit for COVID reasons, and this is an aerosol generating procedure, we use a clear plastic tube with the blue ends.
There's some filters in the bottom of the basket. We're all good. So the other thing I was going to ask Louise, so you talked about the FiO2 at 60%, and we're also on the protocol using the CPAP at 10, aren't we?
Yes.
As a general rule.
Yeah.
But we might, on speaking to the respiratory physicians, etc., that might go up or down depending on the patient needs, but it's always 10 at the beginning.
Yeah, at the beginning, so that we can just get them started nice and quickly. So CPAP tube at one end, and on the side of the machine, it's the only one that sticks out, so you can't put it in the wrong area. And then a filter, and we also have an exhalation port. Because we're using a closed circuit, we do need to make sure the patient can exhale their carbon dioxide. Noisy packaging. Okay.
So the exhalation port's gone on the end there.
Because if you picture your patient connected here, when they breathe out, we need to filter that air initially, and then the expired air will come out through the slots in the exhalation port here, and then the rest of the air can be delivered as normal through that tubing. So we have two types of masks that we generally use. We have the full face shield, and again, when you're putting it on, please make sure it has the blue end. That will always signify a closed circuit mask.
And what sizes do they come in, Louise?
So we have in stock here adult large and adult extra large, but those are American sizes. So if you think of a large as generally a medium and will fit most, but never all patients. So if you could just hold that one there for me. The other type of masks we have, if you do have a petite patient, we do have usually seen masks for NIV. Again, blue end signifying it is a closed circuit mask, and these are much more disposable. And they clip on and off that way. So these come in small, medium and large. So if you do have a smaller patient, I would go for this because the shield mask will be too big. But it's one of those things that you can try. The downside with these masks here, if your patient is staying on CPAP for long periods of time, is the pressure on the nasal bridge, which can cause pressure sores, which then obviously need to be Datex should they occur. Okay, we're going to use the shield today. So normally we would be wearing full PPE, so that would be an FFP3, the hairnet, the full gown, shoe coverings, because this is an AGP procedure. My colleague here has recently taken a lateral flow test, so just for this purpose of demonstration, we'll quickly put it on and then take it off, and then this room will be left to air. So if you don't mind removing your mask. So we're looking for the bottom of the shield here to sit just below the lip in that crease there, and then it should sit onto the forehead, and we want it to fit in reasonably secure around the outside. The idea with these masks here is not to have it wedged onto your patient's face as hard as possible, because it will be very uncomfortable. The idea of these masks is there is a slight inflation with them when you put the pressure through, thank you, so that you can actually allow that inflation to occur. There's also two sizes of the mask. So if you have somebody with a small head, you can use secondary Velcro straps. Go around the back. Oh, sorry, I've got a caught in your hair. And it's clips that clip onto the side.
When you're tightening these straps, Louise, which straps do you tend to do first?
Because the way, if you have a patient who can hold it, it's absolutely perfect, because then you've got time to do all of them in a nice, safe manner. I probably would go for the top one first, just so that you can then get the bottom ones slightly tighter, but it depends on how confident you are with the mask, to be honest. Brilliant, lovely. So if you just relax your head back, the thing to remember is when you lie down, the patient's face will be slightly different. So you do need to adjust it for them in the lying down position rather than sitting up. But to be fair, if they're coming to the unit and they need putting on here, they're not going to fight too much anyway. Okay, so I can see that my machine is set to 10 with 10 centimetres of water pressure. On the CPAP setting, my FiO2 is 60. I'm going to connect up my filter with the exhalation port to here. It's going to come in, you okay? And it's just start ventilation. Okay, so you can be able to hear the oxygen coming through. The nice thing is we know that we're trying to deliver a positive inspiratory pressure of 10. If this number here gets really high, it generally means there's a leak. So as long as it's hovering around about the 10, give or take 1 centimetre of water, it's going to be a good size fit. So let's just adjust that. So what I tend to do is I tend to just hold it onto the face and then remove any slack that is there. So if you can't hear any leak or feel it, then hopefully it's in the right position. That just blowing down your neck.
So you can always ask the patients if they can feel anything, can't you? If they can feel anything coming out.
Try and make sure your exhalation point is blown away from the patient as well. Because if they feel that on their chest, they may think it's the mask is leaking. You can just do, because our hands are so sensitive, a quick run around the outside. That feels good. How's that feel? Perfect. The nice thing about this mask is the patient can talk if they want to, purely because they're not going to move their mouth too much. But obviously we want them to be nice and relaxed and just breathing. Gives you your respiratory rate. Some doctors may ask you to do a tidal volume. that'll be down to them. As you can see now, that's just moving along quite nicely, just letting them breathe. There are different views, should you want them. So some people like to be able to see just the nice rhythm here, and you still have your FiO2, your centimetres of water, positive respiratory pressure, volume, respiratory rate, and imminent ventilation. And then they can just sit and breathe away nicely. When they start getting a little bit better and their demand for oxygen is less, if you click onto the wheel again, which is the settings, onto the FiO2, you have a slider scale here from 21 to 100, and you can either move it manually or you can use the plus and minus. So because she is nice and healthy, we'll just turn that down for her. Okay. And then you hit apply. Oops, sorry. Okay, so it now tells us FiO2 is 27, CPAP is still 10, and we still have our other readings. Back into home, you can change your view back to whichever view you're comfortable with.
So that change in the noise there from being quite noisy is just because the amount of oxygen going through is less.
Yes, so yeah, there's less demand. So it'll be recorded on news as to what their saturation levels are, and there will be a protocol in place as to what you're aiming for, depending on any underlying lung conditions. With patients who have COVID pneumonitis who came in who've never had any lung disease, you'd probably be on the 92 to 96 range. Other patients, you'd be on the 88 to 92. Just ensure that you check which one you're aiming for and adjust accordingly.
Are you able to show us the other mask, Louise? Just
Certainly.
Because I think it's the fitting of the mask that sometimes...
So because it's an AGP, as long as you're reasonably quick, if you press and hold and just put it into standby, and then disconnect quite quickly, because otherwise they'll feel that they've not got any air. I'm going to unclip that. Okay, you right? Yep. So this one here is a bit like a halo at the back of a head, if you think. So again, this one here, you put the mask on first and then the headgear, and that is quite important. Would you mind? Thank you. And this one here is a bit of a pull through. In theory, you should always alter masks symmetrically. If you have a patient who has any facial damage, I would definitely use a shield. Or if they have any jaw issues, definitely use the shield, because this pressure around the side of the face will be too much. Does that feel too tight?
No, it's fine.
Fabulous. Okay. Are you ready? Mm-hmm. So plugging it in and starting ventilation again quite quickly, so that they're not feeling any form of air hunger at all. So again, making sure the exhalation port is facing away and just feeling, is there any leak? The other disadvantage of these masks here is if it doesn't fit on the bridge of the nose, you can get the air blown into the eyes, which can cause eye dryness and again make it very uncomfortable, and your patient being less tolerant of the CPAP machine. Any questions from?
No, I think that's, so it's the shield generally as a first protocol, unless they've got a particularly small face.
Yes.
Where it doesn't fit, or you've got lots of leak, and then try one of these.
Yeah.
Do these come in different sizes as well?
So these come only in small, medium and large, and they are generally what we would expect in a small, medium and large. We don't have petite, so again, you may end up having to go slightly larger on a small if you have a very petite patient. You don't particularly want it any lower than the chin, because the leak that will come out of it will be too much. And also the patients are far more likely to try and keep moving it under the chin, which you do not want because of the leak.
Perfect. So
Okay.
we pop that, yep.
So again, I'm going to turn it off into standby and disconnect. And then to turn this off completely, it's press and hold, and then just power off. Don't forget to disconnect from the wall. And then we'll just take this off. Each of the masks, you should really clean them every time you take them off a patient, rather than every certain number of hours, but definitely every 12 hours as a minimum. I would always clean the mask in between taking it off and put it back in. Clinell wipes is absolutely fine to do that. Filters were every 7
I think they're
days. Was it?
I think they're every 48 hours or
48
something
hours,
like that,
sorry.
weren't they? But again, check the protocol.
Yeah, I think the tubing was every 7 days. Yeah. Okay.
From a patient point of view, Beth, which mask was
I prefer the shield.
the big shield? Yeah.
Yeah, it's a lot comfier, and that the smaller mask is quite obstructive around the eye area.
Yeah, yeah. Because if they are wanting to see your face, because it can be quite a scary process having this on, I think it's much nicer to be able to have that window view.
Yeah.
Can we just, before we finish, switch the machine on and just go through some of the other buttons that are there? Not that we necessarily need to press them, but should an alarm go off, for example?
Keep your hand on that for me. So if I start the ventilation, so we can sort of take it a little bit. Okay. So there is a disconnect alarm, which I'm hoping. Okay. And then when you reconnect it, it will just stop it, or you can just press the red button. Now that is alterable, changeable. Okay. Under the settings, and you can check when the patient's alarms have gone off.
I think it's in the belt. That's it.
In the belt, yeah. And you can have the tidal volume if it's not high enough, or too low, the minute ventilation, respiratory rate, or circuit disconnection. So again, you have the slider scale of anywhere up to 60 seconds before it starts alarming.
So as a default, we decided to switch the other alarms off because we weren't so interested in those. However, if, you know, depending on what we're using it for, etc., we might want to put those alarms on.
Yeah.
And the circuit disconnect was set at 5 seconds, just in case, as we'd had before, patients get up to go to the loo, forget they're connected to this, and it all disconnects and pulls apart. And at least you have an alarm making you aware that something's happened there.
Okay.
And then we went through CPAP mode, didn't we?
Yeah, so again, it's just in that CPAP button there and changing it if you need to, but for the purposes that we're using it for today, it would just be in CPAP mode. If you did want to change the pressure, again, you've got this nice slidey scale, and it'll go up to 25 and all the way down to 3. So you've got quite a large area, but 10 is the general starting point for the protocol that we use.
And the only reason recently we turned it down was because of somebody trying to tolerate, and that was in conjunction with the respiratory physicians.
Yes.
Or when you're weaning someone and the respiratory physician says you can start turning that down.
But or they may conversely say, actually, this patient has some sort of evidence of sleep apnea, in which case you might want it a little bit higher, so you're trying to compensate for the sleep apnea and what's going on in their lungs as well. So we just need to make sure that we've got a nice clear respiratory rate and minute volume.
Lovely. Thank you, Louise. We'll do some questions and answers with Chris Cannell for anything we haven't covered at some point soon. Thank you for watching.